Good afternoon, everybody. Today, our lecture is about nystagmus type and approach. I'm Dr. Maha Badr, Senior Clinical Consultant Neuro-Ophthalmology at Prince Sultan Military Medical City. Ophthalmology examination, systemic and organized approach. Incomplete assessment of patient during routine examination and failure to correlate symptom with sign are probably more common reason for missed neuro-ophthalmic diagnosis, including type of nystagmus. So always important in neuro-ophthalmology to dig in history. We're taking time, taking history, and asking leading question for the patient, like onset of symptoms, complaint of patient, drug use or abuse, like tranquilizer, anti-epileptic, antibiotic, alcohol intake, previous head trauma, a neurosurgical intervention, scissor. All history is very important. So we go for routine full ophthalmic evaluation, include visual acuity, refraction, whether refraction or automated refraction or pinhole. So we have to know what is a patient best vision, visual field if adult, intraocular muscle, intraocular pressure, extraocular motility examination, and pupil reaction. As well as it's always important to check saccade and pursuit, cranial nerve, and to examine nystagmus. Will come how to examine nystagmus in the lecture in a few minutes. Of course, we will do slit lamp examination for cornea, anterior chamber, iris, lens, vitreous. So we are systematic examination. We will dilate the fundus, looking for fundus picture, and then we will see what investigation which we should do. Now let us talk about nystagmus in specific. Nystagmus, it is a term used to describe oscillatory ocular movement that are to certain extent rhythmic. So there is a movement, abnormal movement in the eye, and to certain extent there is a rhythm in it. Nystagmus in general is divided into two types, pendular and jerk. What is pendular and what is jerk? Pendular nystagmus describing ocular oscillation in which the velocity in both directions is approximately equal. Like if you remember the old watch, and there is the pendular movement to both sides. I don't know whether you know about it or no, but this is what pendular nystagmus. Cases of pendular nystagmus are almost always horizontal. Usually pendular nystagmus is in the horizontal direction. We don't see it in vertical direction. So, while jerk nystagmus is a rhythmic oscillation in which the movement in one direction is recognizable faster than the movement in the other direction. So when you see it, you see it moving to one side quick and returning slowly. So the slow movement is usually the pathological movement, while the fast phase is the corrective or the normal phase. But usually we call it, after the fast phase, we call it jerking to the left or jerk nystagmus to the right, according to the fast phase, because it is easier to see it. Null point. What is the null point? Both pendular and jerk nystagmus may have a gaze position in which the intensity, amplitude, and frequency of ocular oscillation is at minimum. So either in null point there is no nystagmus, you cannot see nystagmus, you cannot see movement, or it is the least movement from when you look all the direction, you find that in this position, it is the least movement. And we call it position of relative stability. Now, to make it easy, it's very difficult usually to assess nystagmus. But to make life easier, I usually draw cross like this in the charts. And I make my mind look to the child or to the adult at one position at a time, and I will write it down. What is it? So either I will look to this when I am looking, I'm looking only to the central position. I'm looking only to the central position, and then I document what was the nystagmus in this. I go usually from central, up gaze, down gaze, to the left and to the right. We might go to the supratemporal, supranasal, infratemporal, and infranasal. And I look to both eye open and see what happened in both eye in certain position. Let us see what I did. Like, for example, I make the arrow with two heads when I want to describe a pendular nystagmus, while to this side, left beating, right beating, rotatory, horizontal and rotatory, up beating, down beating, to make it easy, because it's very, very difficult just to look to the patient and without systemic approach and know what's the patient having. Let us see, like I have this drawing, and I'm sure each one of you can tell me what is the patient having here. Like this patient, I can write with two pen, or I know that right is red or blue, left is black, whatever. And then I could say here in the central position, there is a pendular nystagmus in both eyes. Looking up is pendular nystagmus, looking down is pendular nystagmus, while looking to the left gaze, there is rotatory nystagmus in both eyes, and looking to the right is a null point. You know, if you will write this by handwriting, you might take half page. But a simple drawing can let you know exactly what is the patient having. And during assessment of the patient, you look with both eye open of the patient to one anatomical location at a time, like look to the central position and document, look up and document, look down, and so on. So by this way, you can describe what is the abnormal movement for this child or the adult is having. Now, let us talk to the ocular nystagmus and how I'm going. My aim of the lecture is present the most common type of nystagmus and how you are going to approach, how you are going to reach the diagnosis or to know what type of nystagmus the patient having. So in general, when we have ocular nystagmus, we have to go to the history. There is a very important question you have to ask. When is this abnormal movement started? If the mother, it was a child and told you that the nystagmus present in the first 3 months or 4 months of life, why in 3 and 4 months? Because usually the infant start looking and concentrating and can follow the object in the first 3 months. Before, he might have abnormal movement sometimes, but after 3 months they should be able to follow, and usually in a normal child we don't have any abnormal movement. So if in the history something happened in the first 3 or 4 months of life, we will consider it as congenital nystagmus and or nystagmus present in the first 3 months of life, and we want to know what is the type of nystagmus. And here we have 3 types of nystagmus we will discuss, whether it is congenital nystagmus, latent nystagmus, or manifest latent nystagmus. Let us see if the nystagmus was acquired, present at any time after 3-4 months, or suddenly in adulthood, or then we will evaluate it under acquired nystagmus, and we will come to this later on. But let us now concentrate on ocular nystagmus in the history present in the first 3 months of life, and we will discuss these 3 entities: congenital, latent, and manifest latent nystagmus. Let us see. You have a child whose mother noticed that his nystagmus started in the first 3 months of life. So we will consider it as congenital nystagmus. But let us see, is it with sensory deficit or without sensory deficit? What is mean with sensory deficit or without sensory deficit? Of course, I assume that you will have a full ocular examination of the patient to be able to differentiate between sensory deficit and without sensory deficit. Now, congenital nystagmus with sensory defect, after you do full ophthalmic examination and including electrophysiology for electroretinogram and visual evoked potential, we will be able to have and know whether this patient have poor vision associated with, for example, optic nerve hypoplasia, or he have oculocutaneous alpino, he have labor congenital amaurosis, cone dystrophy, retinitis pigmentosa, rod cone dystrophy, or something you see in the ophthalmic examination, including ARG and visual evoked potential, and you considered that this abnormal movement secondary to the ophthalmic finding, and this is, we call it sensory deficit, and usually does not have extra neurological examination because you know it is caused by, for example, albinism. what about if you do the full examination, including electroretinogram and visual evoked potential, and everything was normal? So you don't have anything except this abnormal eye movement. Of course, we have to evaluate the patient from pediatric neurology, that he does not have any other neurological deficit. And if it was only abnormal eye movement, then we have congenital nystagmus. And there is a lot of theory behind what is the cause, whether it is failure of slow eye movement control system in the brain, or a defect in the subcortical optokinetic system. Now, let us see a case. This is an adult. He have nystagmus since young age, since mother was told him that he have it since birth, and it is bilateral, grossly symmetrical, horizontal with rotatory component, and he have Null Point, and this nystagmus is disappearing during sleep. Let us see now the nystagmus, how it looks like. You see here there is pendular nystagmus while looking to the left. When he look in the central gaze, there is pendular nystagmus. Looking up is less. His Null Point is up. As you see, the movement is less up. When he look down, still there is pendular nystagmus, and you can see it's moving to both sides in equal intensity. I will put it again just to be able to appreciate it by yourself without me commenting. Okay, there is pendular nystagmus, congenital as well, and let us see how it looks like. It is pendular. It's moving around in all direction. Pendular nystagmus. Just to show you what pendular nystagmus look like. Latent nystagmus. Why it is latent nystagmus? Because usually it is discovered at school age. When in the school, they start checking the vision, each eye alone, and then the child have poor vision, so they send him to check, and the ophthalmologist find that this patient have latent nystagmus. Latent nystagmus is congenital jerk nystagmus induced by monocular occlusion. That's mean the child with his both eye open usually have no ocular movement or minimal. While when we cover one eye, like here, we cover the right eye, this eye, the open eye will have a jerk nystagmus and the fast face away from the occluded eye. This is occluded, so it's away from the occluded eye. And now the other eye away from the occluded eye is not recognized until later in life. And that's why we call it latent nystagmus, although it is a congenital, okay? Because usually diagnosed at school age. Parent will not notice any abnormal eye movement while they looking to their child with both eye open. Poor acuity if each eye tested individually, because the child with both eye open he does not have any problem of seeing. But when we cover one eye, there will be movement, and he will start seeing blurring of vision. So this is a latent nystagmus. Let us see. This one patient have latent nystagmus, and I want to see the movement of the eye. Although one eye movement is you can see it more than the other, but then the jerk nystagmus is away from the occluded eye. Latent nystagmus. Now, what is manifest latent nystagmus? It's a jerk nystagmus acquired in patient with congenital strabismus, like the patient who have congenital nystagmus. He might have jerk nystagmus in the direction of the fixing eye. Like if this eye is fixing, and the other eye will have jerk nystagmus in the direction of the fixing eye. If this eye fixing, this eye, the jerk nystagmus will be in the direction of the fixing eye. This nystagmus can be converted from manifest to latent nystagmus if the eye are surgically aligned. This is a manifest latent nystagmus. There is another entity, sometimes it's hard to put it with acquired versus congenital nystagmus, which is Spasmus Nutans. Why? Because it might happen between 4 months of life to 14 months of life. But we have to know that it could be, again, secondary to acquired due to intracranial tumor. So usually what the patient have, triad of fine nystagmus, torticollosis, that his eye will be looking to certain position, with head nodding. Nystagmus may be horizontal, vertical, or rotatory, so any type of nystagmus. And usually, if it is not due to intracranial lesion, disappear by itself at 5 years of age. If it is started after 14 months of age, MRI should be done to exclude chiasmal or ventricular tumor. Usually for myself, if I have a Spasmus Nutans, and even if it was before 14 months of age, I will be more satisfied to have imaged him to be sure that this patient does not have intracranial tumor, especially sometimes parents are not sure when it is started. Here I'm showing you a patient with, as you see, she have head tilt to one side, and you see the head nodding. There is fine rotatory nystagmus. I think because she's a dark, it's not clear very much, but there is a fine nystagmus. So you have the triad of head, torculosis, head nodding, and nystagmus. So in this, you have to be sure whether you're dealing with congenital or acquired. Now, as we said here before, just to remember, ocular nystagmus, you went to the history, present in the first 3 months of life, and you ruled out congenital nystagmus. What about if it was acquired? recent nystagmus. What we should go, we will go to the examination. And what's usually the patient complain in acquired nystagmus? He complained of the term which we can medically describe it as osculopsia. What it means? He might describe that the environment moving in the direction of the fast phase. Or he might complain that there is to and fro movement of the environment, mainly in pendular. Or he will say like jelly-like quivering of the environment, juggling of the environment. Sometimes they feel dizzy and they cannot describe, they're just feeling dizzy because things are moving in front of them. So this is the complaint of patient with acquired nystagmus. Now, we are now know that we are dealing with acquired nystagmus. So when you examine the patient and draw your map, you want to know, are we dealing with monocular nystagmus? It's only in one eye. We have the nystagmus. Are we dealing with one eye, or it is binocular? So this is the first category you have to differentiate. You know, it's acquired. Is it monocular or binocular? Okay. And then you examine the monocular. Is it in the primary position or in the eccentric position? And you can answer this as you examine the nystagmus and you draw this cross, double cross, and you put in each position where is the movement. You can tell that, oh, this is in primary gaze or this is in the eccentric gaze. Now, in binocular nystagmus, there is two terms we have to distinguish. Is it conjugated or disconjugated? What is meaning conjugated and disconjugated? Disconjugated, that the movement is not in the same direction. Okay, like they both eye go fast phase in the same direction. While in conjugated, while in disconjugated, why go in this direction, the other go in the other direction, or one go up, the other go down. So this is the difference between conjugated and disconjugated. So let us go back. We examine, we know that we are not dealing, we're dealing with conjugated nystagmus. This is acquired nystagmus, conjugated nystagmus. They both moving in the same direction at a time. It is, we have to differentiate. Are we dealing with pendular nystagmus or jerk nystagmus? Is it spontaneous, like you're just looking to the patient and you see the nystagmus, or you have to do something to see the nystagmus, which is induced by certain direction, or you do something to have to initiate nystagmus. Now in jerk nystagmus, as we said, is it spontaneous or induced? What do you mean by induced? Like you put the optokinetic drum and you see that the eye start moving. Is it you rotate the patient and then you see the eye? You put heat or cold in the ear and you see where is the eye movements. This test done, caloric test for patient who's comatized. Or there is certain position where the patient look in certain position, the nystagmus start showing. So this is what is induced nystagmus. Let us go to the spontaneous. Spontaneous nystagmus. As we said, are we dealing with eccentric position or in primary position? If it is in primary position, there is important question you ask the patient. Do you have vertigo with it? He is dizzy and fall down and feeling everything is dizzy, or he no vertigo. If there is vertigo, so most probably this is an ENT problem, something in the vestibular, whether it is peripheral or central, and you need the assessment of the ENT to rule out causes of primary acquired nystagmus with vertigo, or is not with vertigo. And here we have periodic alternated upbeat, downbeat, or induced. We will come to them in detail. Eccentric nystagmus, it could be physiological. You know, when the eye moves to extremely end gaze in abduction, we might have fine jerk nystagmus. Or sometimes you see it when one eye is paralyzed, one muscle is paralyzed, and the other eye moving, trying to push more. The good eye, the muscle try to push more, so it make the paralyzed eye to move, and this is called law of equal innervation. It might be secondary to drug, so this is very important to ask about a drug, whether patient have any drug inducing nystagmus and or downbeat nystagmus. We will come to it. Let us see some sample now of binocular symmetrical nystagmus. Conjugated. Conjugated nystagmus, as we said, when both eye moving in the same direction, while disconjugated nystagmus, when eye move in opposite direction. Let us give example. Superior oblique myokemia. Usually it is monocular, one eye. And here is a trick in this superior oblique myokemia, that sometimes it is firing, it is not all the time. So the patient come and complain that sometimes he have abnormal movement, for example, of the right eye, and he start seeing jelly-like movement or moving abnormal movement, and then disappear. Usually what we have is uniocular spontaneous firing of superior oblique muscles, and it can be remission and relapse, and induced by looking in the field of gaze of the involved superior oblique. So it can be in primary position, and it can be in the eccentric position according to which action of the superior oblique the firing started. Let us see the video now. And I want you, when to look to the video, to look to this blood vessels, how it is moving, because it is fine movement. Let us see. Sometimes it's very difficult to see the rotation of the eye, but when we look to the one blood vessels here, you can see the rotatory movement. And this is only happen, yani sometimes you have to keep examining the patient, put him in different position, ask him to wait a little bit and see when it happened. So if you don't know there is superior oblique myokemia, you might think that the patient is not having anything because it's remission and relapse. Sometimes it happens after trauma, and sometimes happen without anything and disappear later. Now, intranuclear ophthalmoplegia, we see a lot of patients with intranuclear ophthalmoplegia, and we can see here the eccentric position of nystagmus. And usually, if it happens it is due to medial longitudinal fasciculus. If usually happen under age 40, we have to consider and rule out multiple sclerosis, while if it happened after 50 years of old, and usually bilateral, it's secondary to stroke. Now, you will not be able to diagnose intranuclear ophthalmoplegia unless you are doing saccade and pursuit examination. You might miss it, okay? If you do extraocular motility alone, you have to do the saccade and pursuit. Let us see the patient and I will explain it, and I will put the video more than one time to be able to see. Now look to this old lady. When she looking to the left, this eye had jerk nystagmus. Okay, look again. And when she looking to the right, this eye cannot go to the end. So in this eye, there is lack of adduction. While when she looked to the left side, there is lag. Lag, that means this eye follow the left eye, does not go in the same time. While convergent is normal. Let's see it again. So look to the difference between lag and lag. Lag is following slowly in adduction, while lag does not complete the adduction, and nystagmus on abduction. If you don't examine saccade, you might not be able to diagnose it. And I have a lot of patients who are missed in the diagnosis, and they think they are normal, but they are complaining just simply because whatever examiner done, he did not do saccade and pursuit examination. Let us see this young one eye with MS. Looking to the right is normal. Okay, let us look to the other side and see. Looking to the left, there is incomplete. And you see, looking to the other side, the lag in this movement. Now, let us see conjugated, both eye moving together, and what we call it downbeat nystagmus. Downbeat nystagmus is vertical nystagmus, horizontal movement there is no nystagmus. ولكن the vertical movement, there is nystagmus. And we call it downbeat because the fast phase is looking down. The fast phase is down. And as I said, we call it according to the fast phase, but you know that the pathological phase is the slow phase. Usually, if it is acquired, it is due to cervicomedullary structure disease. It can cause with stroke, multiple sclerosis, cherry malformation, or drug intoxication. Let us see this patient. You see the jerk nystagmus, both eye moving to the same direction, and the fast phase is down. So acquired conjugated downbeat nystagmus. Of course, when you diagnose it, you have to image the patient and refer him to neurology looking for the cause. It is very clear, jerk downbeat nystagmus. Okay, so downbeat nystagmus is due to cervicomedullary structure disease, stroke, multiple sclerosis, cherry malformation, spinocerebral degeneration, and drug intoxication. So you have to have clear history. Now let us talk about seesaw nystagmus. Seesaw nystagmus is disconjugated nystagmus, and you know the seesaw, in the playing ground for children, which they play seesaw up and down, and this is why it's called seesaw nystagmus. Is a vertical nystagmus, can be congenital since childhood, since early at 3 months of age, 3 months of life, or acquired. If it is acquired, we have to rule out brainstem infarction or secondary to head trauma. So sometimes seesaw nystagmus is very clear, and sometimes it's difficult to see if it is not clear, but you have, as I told you before, to look to the blood vessels in the corner and see where is movement. Let us see this patient. And here, this is very, very clear. We can appreciate it quickly that one eye going down, the other eye going up. And if you are not clear, you can put the patient on slit lamp and look to one blood vessels and see whether in one eye going this way and the other eye going up, and you know, you can differentiate between seesaw nystagmus and rotatory nystagmus, because they, in rotatory horizontal nystagmus, they both moving in the same direction, while in seesaw, one go up and one go down. Now, we have here an example of convergent nystagmus is disconjugated. And this is a very rare disease, very rare to see disconjugated nystagmus. And we call it Whipple disease. And Whipple disease is secondary to bacteria attacking the gastrointestinal system called Trophirema whipplei. And this bacteria lead to malabsorption. And sometimes, and the treatment is antibiotic for a while, but the problem is with the diagnosis, because sometimes with malabsorption, not diagnosed, this bacteria, patient go from joint pain to lung problem, to heart problem, to CNS problem, and even eye. And sometimes is diagnosed from the eye, because the patient have disconjugated convergent, And let me show you how it look like. You see, both eye are this is going inside and this is going inside. So they are in different direction. And this is example of disconjugated nystagmus. And sometimes this poor patient, go from one specialty to another. And if we notice this, we will diagnose Whipple disease. And usually the treatment is antibiotic for a long time. So you know here how important to be able to help in diagnosis of rare disease. I just want to show you here example of opsocolonus. Opsocolonus is type of multiple saccade oscillation without intrasaccadic interval. Usually when with nystagmus, we have like in between, you can see that going down and up, going down left to the right, pendulars. But in opsocolonus is multiple saccade without intrasaccadic interval. Let us see, and usually happen in very poor vision or loss of useful vision in one eye. Let us see how it look like. So you see, it's just a saccadic movement going in different direction. So just this is to showing what opsocolonus look like. Now, in conclusion, congenital nystagmus is the most common form of nystagmus in infant and childhood. Acquired nystagmus occur at any age as a result of insult to gaze control system. Ophthalmologists play important role in the diagnosis and localization of the defect. Systemic and organized approach will help reaching accurate diagnosis. And so much more in different type of nystagmus, but if you know how to approach nystagmus, I think this lecture will help you able to know what to do when you have a patient with nystagmus.